Good morning, everybody. It's 10 o'clock. Welcome to the Health Overview and Scrutiny Committee. Today, just like to go through a few notes before we start. I need to inform you this meeting is being live streamed and recorded. Please also note that all remote participants are muted at the outset of the meeting and are only able to speak at the invitation of the chair. Please raise your virtual hand if you wish to speak, and then only unmute when the chair invites you to do so. We need to ensure also that when we do speak, we have our microphones on and turn them off immediately after we've spoken, because the whole system doesn't particularly work very well with multiple people going live. So when you do speak, please introduce yourself for the benefit of everybody watching remotely. Okay. I'd like to introduce everybody, go around and introduce themselves. I'm Jeff Elner. I chair the Health Overview and Scrutiny Committee.
Hey, good morning. Sophie Foster, Overview and Scrutiny Officer.
Rachel Robinson, Director of Public Health.
Pam Mosley, Councillor for Marlborough and Shrewsbury, and member of this committee.
Ed Potter, Councillor for Lowton.
Edward Towers, Councillor for Wem Rural and Wixel.
Nick Bardsley, Councillor for Brighton and Bastchurch.
Bernie Bentic, Councillor for Meal and consultant gynaecologist.
Heather Kidd, Councillor for Cherbury and Merlin.
Tracy Huffer, Councillor for Ludlow East.
Paul Bowers, I'm a mental health nurse by background. I work as head of operations in Shropshire's Health and Wrekin Care Group, which is part of Midlands Partnership Foundation Trust.
Kathy Riley, Managing Director at Midlands Partnership Trust.
Ashley Kendrick, Democratic Services Officer.
Tom Dodds, Council Scrutiny Manager.
Thank you very much. Right, apologies for absence. We've got Gerald Aiken, Peggy Mullock, who is remote, I gather, and Jeff Anderson. Sure. Sorry. Yes, we've got Leslie Brown remote and Laura Tyler remote, who are officers. Would you like to say anything? Say hello to anybody? No?
Yeah, good morning all. Hopefully you can hear me. My name's Leslie Brown. I'm Service Manager in the Commissioning Team, in the People's Commissioning Team at Shropshire Council.
Morning all, Laura Tyler. Morning all, Laura Tyler, Assistant Director for Joint Commissioning.
Good, thank you. Right, so we all know who everybody is. Let's get down to the agenda then. Disposable interest. Members are reminded they must declare their disposable pecuniary interests and other registrable and non-registrable interests in any matter being considered at this meeting as set out in the Appendix B of the Members' Code of Conduct, and consider if they should leave the room prior to the item being considered. Further advice can be sought from the monitoring officer in advance of the meeting. So if anything does come up and you do have a problem, please let us know. Thank you. Item 3 on our agenda, minutes of the meeting held on the 15th of July 2024. Have you all seen them and read them? And do you agree with them? Do we have a proposer to accept them? Thank you. Lastly, we're second, Ed Towers seconding. Thank you very much indeed. Okay, Bernie, was your hand up? Okay, thank you, Bernie. I need to wear my glasses. I think better. Okay. Public question time. I don't believe there's any questions received so far, so we'll move on to item 5, members' question time. And if there's any questions they would like to raise, I don't believe there are any here for the moment, so that's none. Thank you. We have here today also members of the People Overview and Scrutiny Committee who are participating in this meeting. The People's Committee have already done a lot of work on mental health for children and so on. We're doing a joint meeting because there's such a vast area to cover. So we're not going to get it all done today, but we believe we're going to have further meetings to take this forward. But today we have Peggy Mullock, who chairs the People's Committee, who is working remotely today. So we will have questions and interest and dialogue with a joint committee. Right. So today, item 6, adult mental health services, to understand and scrutinise service provision and commissioning arrangements for adult mental health services. I know that we've had a briefing, we've had details of what we're going to cover today. We're going to take those as read, that we've already understood that briefing, because there's such a lot to get through, as I say. I don't want to go over it again at today's meeting. So we will now commence our discussions. And I do have some questions that I want to ask, first of all, just to get us going as such. Adult mental health. What are the current and future needs that the data and intelligence needs assessments for adult mental health in Shropshire? What are the current and projected levels of demand? What are the differences in needs, demand in different areas of the Shropshire Council area? Are there any areas of commonality, demographic, geographic, economic or social groups that need to be covered? Has the demand around increasing dementia rates have been taken into account? Obviously, I think we've got an older population and there's going to be more and more people fitting into that category. Although I do understand that dementia is not necessarily about old age. And how are service users and their families and carers involved in helping to shape the service design and delivery of the services? Is that something that you would be able to address? Thank you.
Thank you very much. Is that better for people? Thank you. In previous years, when we looked at financial planning, particularly last year, we looked particularly at children and young people's mental health, because that was an area after the pandemic which it really had increased demand. And we've now been able to recruit with the additional investment, and we've started to see the waiting list going down. The area that we probably are focused on in terms of financial planning for next year is older adults. Each year we have mental health investment standard funding, which allows us to look at areas that need investment where we've got increased demand. And what we're seeing is we're probably seeing too many admissions at the moment for older adults. And not so much for dementia patients, because we do have a community service that looks at caring for people, giving them intensive support at home. But we haven't got the same for older adults with functional mental health. So that's an area as providers, and obviously you'd need the Commissioner view, that we'd be particularly interested to focus on in terms of the new growth money that we have next year on mental health investment standards. Now that money strictly can only be used for functional mental health. Dementia falls outside of the criteria where you can use mental health investment standards money. And that has been a difficulty for us in previous years, because that means that rather than being able to use money that is kept earmarked with the ICB for mental health, dementia has to come out of with everything else. Has to be prioritised within that. We have seen, as you would expect in a place like Shropshire, increased demands because of the ageing population, because you are quite right that it isn't just older people who get dementia, but obviously that is a proxy measure of it. And we have got a demand and capacity gap in our services around dementia services. That comes to a gap of about, I think it's about 15 assessments per week, but we would need to check that with the graph that we've got on the slides, and Paul will do that for you in a moment. But yes, you were quite right that we need to focus particularly on older functional and dementia services. In terms, we've done quite a bit of quality improvement work in our memory assessment part of the pathway to make sure that we're absolutely maximising the resources that we've had. And after the pandemic, because that group was particularly vulnerable to the COVID virus, we did have a backlog in that service. We have spent a lot of time with waiting list initiatives, and the backlog is coming down. But the difficulty is that once the waiting list initiative money runs out, we will have a significant gap in terms of capacity and demand. So that's why we're particularly interested in looking at older functional and dementia services next year in terms of financial planning. The other really exciting part, obviously, in the dementia pathway is that there's a whole conveyor belt coming of new dementia modifying therapies. Now, you'll have seen in the news that the latest one unfortunately didn't get licensed in the UK, but there's a whole raft of them coming on with two different mechanisms of action. But what both of them will need is an early diagnosis pathway. So rather than it being somebody who's really got signs of dementia, you need to develop a pathway for mild cognitive impairment, which we aren't currently commissioned for. So there are some things that we need to do through financial planning to get ourselves ready for those treatments when they become available. And that is what we want to do in terms of financial planning this year. And then, Jeff, the other thing, Chair, you asked was around looking at the PCN areas in terms. So the way that we do that as providers is we've worked with Rachel and colleagues and our public health team within our trust to look at each PCN as to what the mental health needs are. And we've done that in terms of looking at the resources that we need in the teams that we provide in each PCN area, but also we've looked at in terms of grant allocations that we do. So this is grant allocations with the VCSE. So we've looked at their needs and through grant allocation, develop specific things there. So one of the first things that we've looked at is sort of things like we've done work with the wood to do with woodland and woodland. Yeah, so there's 18 to 25s. We've done quite a piece of work for each PCN area, but also we're just working on digital exclusions, the other area, because in a rural county we do use one consultation, which is our virtual consultation, to help with to improve access for people. But we are aware that for some people that causes difficulty because of digital poverty, digital exclusion. So we've got particular VCSE grants that help around that. And the next bit that we're looking at is around older adults. Yes.
Question. I had a resident in my division who had to have 3 attempts at a phone call because they insisted he needed a phone call. He could never get through it. And in a case like that, digital's out of the question. Just a basic landline, he never got through it. So the phone call does not work for some people who are quite seriously mentally ill.
Yeah. So I think what you're talking about is our urgent 24/7 crisis line, or maybe our access number, which is a call centre. So people do have to telephone to get to access that, and then they get an assessment from the local community mental health team, but they use a mental health triage tool for that. So
I think do something in face to face was necessary, not.
It was on.
It was not the ability to do things. He couldn't cope with a dislocated voice, with somebody he couldn't see. And that's called mental health issues.
I'm just trying to work out which part of the service that would be, where you'd be going through a questionnaire and you wouldn't be talking to somebody. That doesn't.
To access what he needed, he was told he had to answer the following questions. And I was aware of one of them, and he just flipped out. The third one, couldn't do it.
Was that in conversation with somebody? Because there wouldn't be an online questionnaire or anything to fill in.
It was a conversation, but she was ticking boxes and she was saying, you need to answer this question so I can fill this in.
Thank you, Councillor Benton.
Thank you, Chair. Thank you very much for the Mental Health Services report, which was generally quite comprehensive, but in no area did it cover the topic of suicide. And the standardised mortality rate for suicide in Shropshire, Telford and Wrekin currently stands at 11.4 per 100,000, which is significantly above the national average of 10.4. There was an audit that was taking place after the end of the last financial year to look at factors that might inform improvement. And I was told, or we were told at the last meeting, that the report was imminent and clearly with the urgency of it should be available as soon as possible after the end of the previous financial year. So what is being done to assist people who have mental health problems and are contemplating suicide? So what is the suicide prevention strategy at the moment? What are the resources that are currently being put into it? And how are the voluntary sector organisations being integrated into this service? This committee will be aware that the chair of the Shropshire Mental Health Support Group, which is a Shropshire charity, wrote to the council and to the Director of Public Health about a huge concern in the dramatic drop in potential finances available to them and the fact that they would not be able to fulfill their duties. In addition, the legality of the tendering process for the services was questioned and, to my mind, was not answered. Finally, I just want to mention a comment from the chair of the Shropshire Mental Health Support Group about a case study with regard to the ambulance services. And he said one case study that is of interest is that under Shropshire Council funded services, the short-term outreach provision, one of the services we provide, West Midlands Ambulance and MPFT, were struggling with a person who would call services 4 or 5 times per day, costing in excess of £36,000 for just 12 weeks and taking up vital services. Shropshire MHS stepped in during March 2024 and since the person hasn't made any calls. But the correct person-centred approach has been wrapped around with our other services, releasing critical services to provide vital support. So this is a small amount of investment, reaping a huge benefit for the community and for people suffering severe mental health services. What are you doing to address this problem?
Before you answer that, can I bring in Rachel? Because what Councillor Benton has mentioned is something that we we as a committee have not yet talked about as a committee, and it's something that we intend to do. So really, we're talking about information that's come from one source, not across the whole board. So as a committee, we can't comment, but we will be looking at it, and we will be no doubt contacting you, because it is essential, as has been pointed out, that it does affect the future of the service. So I'd like to leave it at that second, but anyway, Rachel.
Yeah, thank you, Councillor Benson. I think there's three separate points you've raised. So if I take the first point around suicides, the information that's been provided by our colleagues at PFT doesn't provide the information on suicides, because we agreed that we would. My understanding was that we will pick that up at a separate at the next meeting in more detail following the briefing that was given, I think, earlier this month actually. We did also, just to sort of tie a later agenda item together, the paper on suicides that was taken to the Health and Wellbeing Board last week, which will give more detail and hopefully answer some of the questions that you're asking. That certainly starts to lay out, I think, and hopefully answer some of your concerns that we're not seeing here. Are we taking suicides seriously? Are we addressing that? And it starts to get some high level feedback on the audit that you mentioned, which it has been undertaken. The whole report hasn't been completed on that, but certainly those themes, and some of those themes were starting to be provided back to the Health and Wellbeing Board. The themes from that audit have then been taken alongside a re-look at the suicide prevention strategy to make sure that we're covering all the right areas, which we believe we are. But obviously, we as you rightly say, this is a really important area. There's a number of actions that have been taken that was shared with the board, but further work we need to do. And as you rightly say, suicide is something that we're all interested in. It's a partnership response. We might be coordinating the response from a public health perspective, but it involves all partners. So I'm happy. I will share directly that report with yourselves. I expect that Scrutiny will want to get into some of the detail, absolutely, and make sure that we are addressing the challenges that were laid out in the suicide prevention strategy to make sure that we're actioning those. I think you rightly mentioned there that the high rates, the latest figures start to show our rates have started to come down, but we're absolutely not complacent about any of this. What we're saying is we absolutely need targeted action. There's a range of actions supporting some of our most vulnerable groups that we're working collectively on with partners. One of the biggest issues is around communications. That came out of the Health and Wellbeing Board as well. And I know this committee's picked it up. We need to be communicating to people where you get help. Also being suicide aware and making sure that everybody's got the training, that we reduce the stigma around suicide and enabling people to talk. There were a couple of the key points that came through in the work that's been undertaken, but what more we need to do. The conversations at the committee were really positive in identifying further groups that we need to work with, because as we know, a lot of individuals, we need to, in particular in our rural county, we need to make sure that we're reaching out and offering the support and linking into some of those services and tailoring services to meet those needs. So they were that's a highlight of some of the conversations that I undertook. I will send the comprehensive paper, the links to the comprehensive paper around, and I'm absolutely happy that we cover that in more detail in the next section and some of the key lines that you may have. But I just wanted to give you a reassurance that we haven't neglected it. It hasn't been included in the papers today for a particular reason, but actually we wanted a real focus on that, is my understanding, as a future work programme. I think the two other issues, I think, Chair, you've already mentioned the particular conversation around the individual recommissioning service, and I know some of that, so I won't say any more around that in terms of response. The final bit, it would be great if I could have a bit more information in terms of the service that and the particular case study, I think, outside of this meeting that you were referring to, because it sounds as if some of our joint services already are involved in supporting, but I'm happy to work with colleagues and they may want to say more to follow that up to make sure, because we are trying to invest in some of these multidisciplinary services together to make sure, you're absolutely right, we wrap that support around it, and Reset team being one example of how we're doing that with our drug and alcohol community. So absolutely a model we want to build on. But if I can have a bit more information maybe outside, I can follow up on that.
Thank you. Can I just ask, when is all of this information going to be in the public domain? Because here we are over 6 months into the new year after these worrying statistics and lives lost, and we have very little in the public domain about what's happening. And additionally, the commissioning process seems to be not as transparent as it might be. And I wonder if we could have a little bit more detail on why certain members of the voluntary sector are competing for a substantially less amount of money and being grouped into areas that may not be entirely appropriate. Thank you.
It's just in terms of the suicide information that is in the public domain. It went to the Health and Wellbeing Board last week in terms of the update we provided and a summary of the findings we have to date from the audit. It's obviously taken a considerable amount of time to go through each of the cases over the summer, and we'll put high level summary into the public domain because obviously there's quite a lot of detailed information in there. So just to give you that reassurance that process has started. We've been very open at previous boards around the change in direction. To be honest, we'd flagged we were concerned about this for some time, that we would expect to see through COVID and then cost of living a delayed response, we would see an impact in our communities. I think we all agree that our communities are vulnerable, that our mental health is a real concern for particularly in some of our rural communities. Some of those rates in children and adults we've seen increasing. So we've been talking about that, but in terms of the actual information regarding the audit, we've started to publish that as we can. And that went to the Health and Wellbeing Board last week and will come through to this committee fully as well.
Tracy.
Chair. One question I'd like to ask. Do you think there's missing capacity in the acute sector for people with mental health? I'm talking about Redwoods in particular. I know of one case study of a patient that was waiting, a person that was waiting 2 weeks to be admitted. In that time, they tried to commit suicide because there wasn't a bed available. And I know there's very limited space in Redwoods. I've spoken to the clinical person, the lead in Ludlow, Nick Swift, and he is tearing his hair out sometimes because he cannot physically find a bed to admit people. So that obviously there's a link there that's not, we haven't got enough capacity. And also there's another issue. I know of another person that was in Redwoods, had been in there 3 months. By the time it's time for them to be discharged, they had to go back out to become homeless because their social housing was no longer available. They'd lost it and they couldn't manage the system. They weren't capable of managing the system. So that person went back out on the street with very little help, only to be admitted a month later and tried to commit suicide again, was sent back into Redwood. So there's obviously a link somewhere missing for the support for these people who are being discharged from Redwood and not enough capacity in the first place to help these people. Just wondering if we got any ideas about how we're going to increase capacity and support.
We are in the lowest quartile in the country for beds per population. There's a national inpatient strategy that each ICB has had to develop, a 3-year strategy, and as part of that, the ICB and MPFD commissioned an external company to do a bed modelling review. This is very recent, so it's only about 6 weeks ago that company published the report. If nothing was done, so if we made no other changes, at the end of March 26, we would need an additional ward in the Redwoods. But the company made a number of recommendations of things that we could do that might change that bed impact model. One of the things, something I alluded to earlier, was the development of improved community services for older adults. So I touched on the fact that we've probably got too many people being admitted where if we've had improved intensive support in the community, probably wouldn't need to go in the first place. And that's really important, isn't it, for older adults? We all know that actually by being admitted, they can get deconditioned and things. So that's one of the interventions. There was also a recommendation around improving our crisis offer for adult mental health. So that was particularly looking at strengthening the crisis team and capacity for home treatment, but also looking at the provision of crisis houses within Shropshire, Telford and Wrekin. So that could act as either a step up or step down. At the moment, we haven't got a very big provision around crisis houses at all. So there were options. It was quite a lengthy report, and I'm quite happy to share that report with the committee if that would be helpful. But there were a number of things that we would like to be able to try and look at the investment for in the community, rather than necessarily straight away building a ward, because obviously that's the most restrictive of interventions. But what we intend to do, and what the strategy, ICB strategy says, is that as we develop the interventions, we've got an operating tool that we can then put the data into to see whether or not that's changed the forecast around the number of beds that are needed. If it doesn't change the forecast, we need to then move to a strategic outline business case for another ward in Redwoods. When Redwoods was originally built, there were the footings put down for an additional ward, but it would still require capital, obviously, to build it. We haven't got any empty wards on the Redwood site. So there's nothing immediate. That's why it's quite important that we try the community interventions first, because that would be more imminent in terms of improving things than actually building something.
Can I ask that you do actually send information on that report? That would be very helpful.
Yeah.
And I also would like to understand, when you say care in the community or working with the community, are we talking about virtual wards? What are we talking about? And if it is virtual wards instead of beds, how close are we to actually making that a reality? And is that the way we think we should go?
So virtual wards is more of a physical health term. What we have is home treatment within the crisis service. So we're treating people in their own homes. I suppose that is equivalent in some ways to a virtual ward. But I'm just going to hand over to Paul, because I know you wanted to add to that.
Thanks, Kathy. Yeah, so we've had, I suppose, a mental health version of a virtual ward, if you like, for some significant time. I think crisis resolution home treatment teams were developed sometime in the early 2000s, about 2004. So we've had a strong focus on trying to support people to remain well in their own communities and support them to leave hospital when they've needed to be in hospital as well. So it's, whilst the name has changed, the concept in mental health has probably been around for a slightly longer period of time, I guess. Just back on your point really around capacity in acute care in the Redwood Centre. We are doing a couple of things around that. You know, Kathy's given the overview really of where our system sits in terms of its available capacity, but we've seen some significant improvements in our relationship, operational relationship between MPFT, the local authorities, and the Integrated Care Board as well, in terms of a daily focus on what we call in mental health care clinically ready for discharge. So that's the people who don't necessarily need to be in hospital any longer, just need something, some less significant thing to be able to be put into place in a community setting. If we can keep flow going through our hospitals effectively, we can create that capacity that means that when people absolutely need it, we're able to get them in a timely way. So there's daily focus on that. And then we also run events which are called multi-agency discharge events, which includes in the title. We bring people together from the ICB, the local authorities, other areas of the health care economy, to think about the people that we've had in hospital for long periods of time, to think about the things that are delaying getting out again, so that we can make sure people are in the right place to receive care, but also make sure we've got the capacity to bring people in a timely way as well. The fact that we may not have a bed in the Redwood Centre does not stop us and will not stop us looking for beds. We actively use the beds at St George's Hospital when we need to. They're obviously part of the Midlands Partnership Foundation Trust estate, and we will continue to and do use beds in acute hospitals out of area and even the private sector sometimes as well. Clearly that's not desirable, and we want to keep people as close to home as possible. But if for whatever reason we were particularly log jammed at Redwoods, that would not be an impediment to us looking forward and finding a bed for somebody when they needed it. Thank you.
Thank you very much. Are you able to to access beds then from other areas. They have capacity, excess capacity.
You will hear sometimes, Chair, that there is a national shortage of beds, so it isn't a given that we can always find a bed, you know, in the exact sort of split second that we need one, but we will continue to look for beds and we will eventually find beds for people as well. But sometimes for reasons that I don't pretend to understand and wish I did, you will have log jams across the system, regionally and nationally sometimes as well, where there's just not the capacity we need across the entire mental health inpatient system.
So these beds are out of the area, could be out of the area.
Yes, yeah, that's what I say. If somebody needs hospital care, we'll endeavour to find it wherever it is, close to home as possible, in the caveat.
A couple of things. My experience, the pressure on Redwood's beds has not been great for another resident in my community. She was actually sectioned 3 times. She should never have been let out because there didn't seem to be any learning around what was going wrong when she went back into the community. And it was only her advocate and I, who sat in a multi-agency team, who said, do not let her out of the tablet. She will not take them. She has got better and better since we told the clinicians and the multi-agency team that after 3 real crises where she was actually using huge amounts of community resource, police, ambulance services, all sorts. And I put that down to the pressure on the beds in Redwood. They just wanted to get her out. She'd stabilised enough. And then lo and behold, 6 weeks later, she's back in again. You know, that is not a solution. So there's some learning that I'm really worried about that goes on around Redwood because of the pressure. So, secondly, I'm all for keeping people out of hospital and so on. And my concern here is when you begin to implement these things in the community, how long is that going to take to actually happen? And then if it doesn't work, which I hope it does, it will take you 2 or 3 years to build forward. So we're talking about a 5-year plan here for people who are mentally ill now. So I'm really concerned that actually this committee needs to begin to want timelines, and we begin to make recommendations along what we can do for those people we have who are significantly suffering now and over the next year or 2. So how quickly are these interventions you've been talking about to keep people out of hospital likely to take place?
The current plan that the ICB have got for the mental health inpatient is a 3-year strategy. So there are timelines linked to that, and it's published on the ICB website.
About these new ones?
Yes, it's part of the 3 years. 3-year strategy. There's different things in different years, because obviously it depends on funding and new investment.
That is the really important point to us. Government needs to realise that there's significant harm, whichever government is, whatever the politics is. Actually, it's those people who are mentally ill now that we need to be looking at, not those who are mentally ill in 3 years' time.
Thank you. Laura.
Thanks, Chair. Just to add in terms of some of the accommodations and the work that we're doing around that, and also the work with providers across the market as well. So we have got obviously supporting people in the community is a focus, as Kathy's rightly pointing out. We've got dedicated accommodation for people with mental health. We are looking at bringing online another 14 units next year too. I think Leslie might be able to give a bit more overview on that. We're also just looking at what the additional needs will be from an accommodation perspective. So we've commissioned some housing research to look at the accommodations and exactly what we'll need. And that's not just mental health, that will be right across in terms of older people's carers, etc., and also the general workforce. I think it is fair to say that one of the issues that we do have is around providers and their ability and capacity to support people with mental health. So that is another big piece of work that we're trying to do with providers at the moment, scoping what it is that they need in terms of training and support to ensure we've got that capacity within the wider market as well. I don't know whether, Leslie, you want to add anything in addition to what I've just said.
Yeah, thanks, Laura. Yeah, absolutely. And that joined up work on the pathways from acute settings into community is something that is a priority for us. We've recently invested in a permanent mental health commissioner, and she's doing a lot of baselining work around that aspect at the moment to make sure that we can meet the future demands and support step down from acute settings into community supported accommodation. We know that there are challenges, like as Laura said, in terms of provider market, but we are pleased about the plans for those 14 additional units next year. Would be a combination at the moment based on what we can see on our planning list, and those are a list of people who have needs who we feel would be met well in a supported accommodation kind of setting, of people who may need permanent settings or people who may need almost more temporary kind of 6 months, 12 months, 9 months, because of the kind of cyclical nature or the kind of temporary nature of their supported needs before they could maybe step down into a more independent setting as well. So we're trying to look at the model there so it gives maximum flexibility as well. But also just to mention that, you know, those provider conversations around training and skills mix within providers to support in the community are very much live at the moment. We've got an upcoming provider forum, and there are aspects of that we want to bring into that. That's probably going to be in the next 4 to 6 weeks as well. So very keen to share this challenge, I guess, with our providers, and they're willing to step up as well. Thank you.
Brilliant, thank you. I was going to ask about training and staff retention and so on, so that's good. At least you're onto it because it's obviously going to be much needed. Okay, Heather would like to respond.
Can I just come back on all of this? And this brings me to a point that I've been considering for some considerable time, is that we have all sorts of different people delivering different aspects. And it would be much better if, one, when NHS England gives you, I presume it's them, various pathways to be working up, that they were working across the board with everybody so that everybody knows what's going on and it was all integrated, because I think we can achieve a lot more if it's more integrated than it appears to be at the present time.
Thank you. I agree with that entirely. Hilary, did you want to ask somebody? Your hands up. You're on mute. You're on mute. Can't hear you.
Okay, can you hear me now?
Yes.
Hi, thanks. I think you've touched on some of this question that I want to ask, but I just want to ask about the commissioning the right services. So how are services to meet these needs and demands identified and commissioned? And what is the plurality in the market to deliver the services in this area? What is the competition and the provider choice? How does this differ for service types and locations, etc.? What is the right mix of service to achieve the required outcomes at a population level and or individual? How long are commissioned service timeframes? What are the timeframes based upon? And how confident can we be that what is commissioned now will be still fit for purpose in 12 months, 2 years, 3 years, or maybe 5 years' time? Thank you.
Before you go on to that part, could I just ask a question on the first part?
Of course you can, Peggy.
It's the last question that was asked. How are service users and their families and carers involved in helping to shape the service design and delivery?
Good question. Thank you.
Thank you. You're right. That got missed, didn't it? Without sounding too vague, and I'll try and be as specific as I can within that, in a range of ways. So at some, we've got surveys, we've got the friends and family test that involves people in being able to rate the services they've received. We have the concerns that come in through our patient advice and liaison service, and sometimes through the formal complaints mechanism by which we take feedback and learn from that. We have people who are employed specifically because of lived experience with mental health problems, so that we can start to tailor our interventions more thoughtfully, perhaps to people who are experiencing our services as well. We use something called the triangle of care, which you may be familiar with, which is a way of making sure that carers, service users and service delivery is joined up in that sort of triumvirate way. We certainly, as far as is humanly possible in all our projects, but certainly with the big transformational projects as well, we have service user and carer representation on our steering groups and in our working groups. So in terms of the 3-year community transformation programme we've just been on, we did exactly that. We sourced people who wanted to work with us to help shape what that community service looked like going forward, and we had those people physically represented where they wanted to be physically represented, or certainly consulted and involved in terms of being able to provide feedback about the plans that we were producing. And again, in terms of the next 3-year piece of work that Kathy's described around inpatient quality transformation, we are in the process at the moment of sourcing through our engagement team people who want to be involved in that, whether it's physically involved in the design of the work, if you like, around a table like we are now, or whether it's people that want to be involved in sort of critiquing and commenting on plans and proposals we bring up during the course of that work. In terms of, I know I'm dancing around a bit really with this, but in terms of going back to actual, the one-to-one conversations we have with people, our care planning is user focused. It is about understanding what people's goals and aspirations are when they come to us to receive services, and finding ways through things like patient rated outcome measures, clinician rated outcome measures, whether we've actually delivered what people wanted us to deliver. If you come to me today and you say my goal is to do X, Y, and Z, we need a way of being able to objectively measure whether you have, you subjectively yourself measuring whether you have been able to meet those goals that you'd set jointly with us as well. So there isn't a simple answer, isn't it? There isn't a sort of one simple answer I can give you, but we involve people throughout our service delivery. I hope that's helpful.
Yeah, that's fine. Thank you.
Good, thank you. Laura, you want to respond?
Yeah, just thanks, Chair. Just picking up on a few points, and I think just to echo Paul's I think comment around there isn't one size that fits all in terms of carer involvement and how how they inform services. So again, very similar in terms of our commissioning approach and how we see that. So from an operational perspective, as part of their reviews, it's very care centred. What is their outcomes for their care plans? That will inform, is that working, is that not working, and then we'll adapt it according to that. We also monitor and inform changes to services through contract management. So, part of that will be compliments, complaints, what's working again, what isn't working. So that will inform service design around that and changes. Some of the larger projects will always, again, similar to Paul's comment around the involvement from carers and experts by experience in there. We've also, just as part of our restructure, embedded a co-production lead, and one of their roles is to widen that expert by experience panel that we want to be able to do. So we'll be able to get people far more involved with some service redesigns and the work that we're doing. But those individuals who are utilising services always will inform changes to things in terms of what is working and what isn't working. I'll leave it at that point, but I could probably come back on some of Hillary's points if you want me to do that now as well, Chair.
Up to you. Do you want to carry on now, or do you want to come back to us?
If I carry on, Councillor,
okay.
and just answer some of your questions, because I think, in fairness to MT, there's a wide commissioning approach. I suppose you've got your clinical bit, which we're talking about from an MPFT perspective, and then there's obviously a wider kind of the social, the health and social care approach from a commissioning perspective as well. So I think In terms of, you know, how we identify need, there obviously we talked about the GSNA and the information that's informing the demand that's coming through. Again, from a contract perspective, we'll be looking at trend data to inform how we change those services. Thinking about one of the things with the contracting that we try and do is we speak to the market about what is it that they want to see in terms of length of contract and what would, because we've got to think about how we're sustainable and how we work with our partners and our providers to ensure sustainability across. So providers will tell us that they would like a longer term contract so they can really embed and develop services. So that's something that we will work with them on. We'll always be able to change and amend contracts, you know, we as far as like that kind of negotiation, or even end contracts if we need to. So councillor, your point is, how do we know if things will change for the future? Well, we can change it. We've got the ability to do that. I think is really key. We do review it annually as well. So as part of the commissioning cycle, when things are coming through Joint Commission Delivery Group, we're looking at everything is based upon what's the demand saying, what's the trend saying, and what are individuals saying about those services. So these will inform any kind of service redesign, and things will not go through unless it's really there's evidence based upon that. And just you know, when we are really working really much more closely with our ICB and health and social care colleagues around that, and looking at how we align some of the services a bit as Leslie was talking about earlier on in terms of those pathways. So I don't know if I answered all your questions, Councillor Luff, on that, but I'm happy we'll come back on any of that.
That was very helpful. Yeah.
Can I just ask that you mentioned ability to change contracts and so on. What do our service providers think of that? I mean, we're obviously looking at how it affects those in need, but what about the actual providers? Are they happy with the way things are going and how we're going to be working in the perceived future?
Yes, that's good question, Chair. As part of that conversation, so when Leslie was talking about, you know, our development and work with our providers, it's those conversations that we're having around that flexibility and you know, we need to be able to adapt and flex as they do too. So, you know, if they are, you know, if they need to change, then we have to then listen to them as well. So it's a two-way relationship with them. So it's really important that we have that. It's important that we have that contractual relationship with them as well. I think, you know, what we want to do is far more contract and commission on outcomes. So it's not on digits and widgets and counts of this and accounts of that. It's much more, are we meeting the outcomes of the individuals? So that is where we're trying to get to. So that there is no, you know, I suppose not everything is black and white from that perspective. So we need to be able to do things very differently and be able to adapt and change. So that is definitely something that's really key for us, is to develop that relationship with the provider to be able to do that bit of work. But I think they are receptive to that. They understand that things are changing, and as things are developing and new technologies or new demand and stuff, they're very aware of that, and probably more so willing to probably be a bit more flexible and a bit more integrated in terms of some of the work that they're doing than probably have been in previous years, really. That would be certainly my take on it. Clearly, that some providers, they will want to stay with what they want to, they know and what they do. And it's about that work, isn't it? And about that relationship and informing what the needs are. So as part of the market position statement that we've developed, you know, that is informing on where we want to go and what we want to be able to do. And obviously one of our commissioning intentions is to align, you know, mental health and wellbeing across all service areas. So it's about how do we do that with them.
Good, thank you very much for the comprehensive answer. That's good. Councillor Towers.
Just going back a little bit, actually, it's possible. We talk about capacity. Yeah, it's fine to hear about you thinking about wards that got foundations in, or maybe have walls putting up, intervention in the community and all that sort of stuff. But the experience I've got as now having to be for our residents is, for now, I have a gentleman, you know, for example, who gives me a phone call I have to go and see, whose problems are be dealt with now, and he cannot stand on the phone. He cannot take question after question. That's why I have to be there to some extent. But it's just getting through and getting him sorted now, whilst all these wider plans that Laura's been talking about, you've been talking about, are put in place. And yes, there should be informed and evidential reasons for putting things in place, but in fact, it is the now for some people. It's the emergency stuff that we want. We need to reassure our residents of that there's like a temporary place that these people can go until your bigger plans are in place. And I just want to know what your thoughts are on that, really.
I suppose there's a couple of things I'd say on that, really. The first thing is, in general terms, for all of you, you've all given some good examples of people that you know or are close to. If that feedback hasn't been received by us as an organisation yet, then if people are happy for you to share it, then please do share it, because that's the best way we can learn, is by understanding, is being able to go back and look at what's happened internally. So the narrative you're giving is helpful around that, but if we can take that back and do a little bit more digging, that's invariably more helpful to us. There's already a couple of new ways in which people can get help urgently when they need it that didn't exist 12 months ago, one of which is an initiative with West Midlands Ambulance Service, where we've got dedicated mental health ambulances now that cover the county as well. I think weirdly it works out at about 1.5 ambulances. I'm not sure how you have half an ambulance, but it's capacity that's shared with a neighbouring region. But so when people, if people dial 999 in an emergency and they need a health service, that can potentially be channeled through into the mental health ambulance vehicle instead, and a dedicated response given there. We've also just rolled out, we've done it locally, but it's part of a national initiative that the NHS 111 number now covers mental health as well. So if you phone 111 in health with an urgent health need, you'll have the option to speak to somebody about a mental health need. It's sometimes called option 2. I don't think it's option 2 for us necessarily, it just refers to the mental health option, and that's available 24 hours a day, 7 days a week as well. That the national rollout of that started earlier on this year, and you're probably likely to see some more communication about it as part of the winter pressures campaign that the NHS does as well. So not only signposting people to the alternatives there are to manage their physical health conditions, but signposting people to the hopefully relatively easy access, notwithstanding the fact you need a phone, etc., to get that. So I hope that helps us to show you that there's already things happening. It's not that we're sort of in stasis necessarily while we wait for plans to happen. We're already delivering previous plans as well, which are making a difference.
Thank you, Paul. That's exactly what we need to hear, really. It's not waiting for things to happen in the future. It's actually the now as well. And that's reassuring to know that those steps are being taken. Thank you.
Good, thank you. Can I just ask about where does prevention sit in the system? Are we, the way I'm reading it, we're pretty reactive. Are we being proactive? Are we actually looking for pointers saying that such and such isn't very well, or this is happening, or whatever, and where they can go? Or are we just waiting until they report and say, I'm not very good, I need some help, and then they're in crisis? Are we actually preventing things from happening?
Yeah, again, it'll probably be a wide-ranging answer, I suppose, in terms of that. So Kathy mentioned earlier some of the grant allocation work that we're doing with the voluntary charitable and social enterprise sector. That's exactly aimed at getting resource into grassroots resources that people can access in a very low-level way that helps keep them well and supported in their own communities. I completely lost my train of thought and what else I was going to say around that. Oh, well, yeah, we've got what you might have heard of as IAPT services before, improving access to psychological therapies. They've been rebranded. They're NHS Talking Therapies for Anxiety and Depression now, but again, helping people at that, I suppose, lower end of mental health need to get help when they need it so that things don't deteriorate, become worse. In terms of severe and enduring mental ill health, we've had a service for a good while now, an early intervention in psychosis service, which works with young people from the age of 14 upwards. Obviously, the quicker you can intervene when someone experiences a first episode of psychosis, the much better the prognosis is for the course of that illness over time. So again, if we can catch people early and help illness, help debility, help help people not become more disabled by that illness over time, and that's a really good thing. And then we're also re-looking again as part of a national programme around assertive engagement with people who find it difficult to maintain contact with services for a variety of reasons as well, really, so that we don't let those people fall through the cracks, I suppose, for want of a better expression, really. And then I think the other thing I'd throw in as well is the rough sleep of service that we provide across the region as well, in partnership with the local authority, really, which again is making sure that we're proactively finding people to help them get engaged with healthcare services, whether that's physical healthcare services, mental healthcare services, substance misuse services, etc. So there's that proactive reach out into the community as well as the reactive stuff that we need to do in a crisis when, for a variety of reasons, people need something now from us. So there's also, Kathy's desperate to come in, but I suppose I know what the focus is adult mental health as well, but obviously it's our children and young people that grow up into adults, and if we get things right for children and young people, if we focus the correct levels of intervention across our child and adolescent mental health services, in theory, again, we stop or prevent the severity of the illness. You know.
Is there a natural flow between child mental health and adult mental health? I ask this because I have somebody that is 17 who's been referred. I don't know, you said been referred. I don't know how long it's going to take for him to actually see somebody, but he's 18 in January, so he's going to be an adult then. So is he going to get a letter in January saying, you know, you need to be referred to adult mental services, or are they joined together and picked up?
Broadly speaking, joined together and picked up is what I'd say. There's we have what we call transitions meetings as well. So we look at the referrals that come in, and when someone's on the cusp of sort of 17, 18, you know, entering into sort of technical adulthood, we'll have a think about the type of service that that person needs. And, you know, for the sake of a few months or something like that, it's not worth a CAMS service picking that person up. Might as well start the journey with adult services and see where they go. That said, the CAMS service, as you probably know, is a birth to 25 service. So actually, if people have been in the CAMS service, we will, if that's what their needs are likely to dictate, allow them to stay in that service up till the age of 25 as well, so they don't have to transition into adult services if it looks like, you know, a problem, a condition will have worked its way through by then as well. So we're not hard and fast on that for the CAMS service.
And my other question I'd like to ask is about locality. We hear lots of cases of people having to travel across the county to access services. Are there any movements to introduce services into market towns? You know, I live on the Welsh border in Ellesmere in the north. Heather has similar problems. He lives in the deep south. You know, it's as though we're in another world sometimes. And you know, I'm not joking. We can't access broadband very easily. We can't get public transport to certain areas. How are we addressing those things within the community or the local community?
Thank you. I think it was, Kathy's hopefully got it up. I think slide 2 of the set we provided gives an indication to the committee of the areas that, where we are geographically located as well. So for understandable reasons, hopefully we've got a big centre in Shrewsbury itself and then another one in Telford. We've also got bases up in Oswestry, across in Market Drayton, down in Ludlow and Bridgenorth as well. And then our NHS talking therapies for anxiety and depression also are more embedded in communities as well, and are operating out GP practices, health centres, etc., etc., etc. So where physically possible, show me something else, and I can't look at that and think at the same time. What?
I was just going to add that obviously we are community services, so it's important to note that 29% of all our booked appointments are done in what people would class as their own home. So although we've got the bases, there is a lot of home visiting and home appointments as well.
Thank you. Yeah, that's great. Yeah, so again, we always aim to tailor our services to what people need. So if people, for a variety of reasons, don't want to be seen at home, want to go to a base, we've got the bases for people to go to. If for whatever reason we need to get into someone's home and work with them there, that's what we'll do as well. If they want telephone consultation or virtual video consultation, we can facilitate those things as well. So we try and understand what the individual's needs are and offer a range of responses based on that, really.
Heather.
It's really interesting, and looking at the map, and I did realise it was slide 1 and slide 2. Actually, the main bases in South Shropshire are only in Bridgnorth, which is actually an hour away from me, or Ludlow, 45 minutes. So what do you do about people who want to go to one of these bases but can't? There is no public transport to those places for us. Absolutely none. So there are all sorts of issues around that. I would also be interested to see how much treatment actually happens in people's own homes in very rural areas, because there must be significant cost pressures on travelling into the deepest south. The time, the resources around that, diesel, is significant. And therefore, how you limit that, because there must be mechanisms limiting it, or you will run out of money if many people want to be treated in their own homes. So glad to see that we've got home visiting going on. And I do remember talking about this before when we were doing the rural proofing, but actually the amount at that point wasn't that great. So I'm concerned about the resources that are available, how many people you actually manage to treat in their own homes, and their access to that. I think also listening to you around 111, I don't think people realise, and I think we need to do more communication about this, that actually families and people who are facing a crisis with a relative at home need to know they can ring 111. I don't think they do. There's a whole range of things that need to be re-impressed on the public so they can get those. And my second question is around these ambulances. Our experiences of any ambulance are not great in Shropshire. Even if you ring 999, you can wait many hours for an ambulance to turn up. So if you have somebody in crisis who wants one of the mental health ambulances, which I think is a brilliant idea, how quickly do they get there? And are they solely for mental health? Because my concern is that the West Midlands Ambulance Service, if put under pressure, will use them for other things, because that's what they do all over the place. If we had a crisis in Shropshire and our mental health ambulance, 1.5 of the ambulances is actually out in the West Midlands, we won't have anybody. So there are all sorts of questions I have around that. Not to say what you're doing isn't good, it's just that I need to know how good it is.
I believe there is a report that the ICB have received from West Midlands Ambulance with regard to the new ambulances, which will have that detail. I wonder, Jackie, whether you could be able to forward that to the chair.
I don't
say welcome to Jackie, because you couldn't get it for a while, could you? I understand why, but thank you. But it's not your, yeah, thank you for persevering and coming. Paul.
Thank you, Chair. So yeah, just coming back on that, I mean, we don't ration care based on where people are. So we will always endeavour to understand what people's needs are, like I said in the previous answer, really, and work with that as best we can. And yes, if that costs an extra £1 or whatever it is per litre on unleaded, then it costs an extra £1 or whatever it is on unleaded. But if we need to work with people in their own homes, if we need to move people out of bases to get into communities further, then that's what we do. So again, like I say, if you feel people aren't experiencing that in reality, I am only too happy, and we're only too happy as an organisation to hear directly about that. So please do tell us. The other piece as well around the mental health ambulances, my understanding is yes, they can be deployed for normal, in inverted commas, duty if if there's a mental health job lined up. But going back to something I mentioned in one of the previous answers, really the crisis resolution home treatment team, we are commissioned to and held to account for providing a response, a face-to-face response to people anywhere in the county within 4 hours. So if it is that for whatever reason the mental health ambulance isn't available or isn't appropriate, we've got 24-hour, 7-day-a-week coverage of Telford and Shropshire by our crisis teams, and we have, what's it, Jackie, a 95% target on that we have to hit on those face-to-face contacts, and we have to be able to account for the ones that we've missed and explain why we've missed them as well. So we do that monthly. We review that internally, but we do that monthly as part of our contract review meetings with the integrated care board as well.
Before I pass you on, Tracy, I know what's asking a question. Can I just ask, if you have a mental health ambulance, where are these patients triaged? Are they triaged in by the ambulance staff, or when they arrive at a destination of a hospital?
No, you've hit it. It's when the call comes through, it's the control centre, West Midlands Ambulance Control Centre, that triage.
Tracy.
Just going back to you touched on CAMS, which is probably the worst waiting list ever for our young people, because they wait for months and months and months and months. I've also been told that being at that sort of like the backup with CAMS has finished. Is there anything do we see anything in place that might be coming in to replace that? And also you touched on outreach teams, which are our local one in London is absolutely brilliant. They work fantastically with homeless people in crisis. I'm also told that their funding for next year is not secure. So what happens then, because the amount of work they've put in has been fantastic, and I don't quite know where we'd be without them. And also, sorry, I'm going on here, the implications of using a local travel lodge for people in crisis. We have people with low level mental health issues, maybe drug and alcohol use. They're put in a travel lodge, which that's going to have a cost implication. And I think they're often discharged because they're not suitable for a travel lodge, to go back out and become homeless again or in crisis or in need. But really, what are you doing around perhaps finding best solutions in a travel lodge for these people? Some of them are young men that have been released from prison. We've got several locally that then they go in travel lodge for a short space of time. It's totally unsuitable. They come back out and they're back to in crisis again. But is there any work being done? I hear that there's some more units being built, 14 units or whatever, but are these going to be for these young people that seem to be pushing people to place, whether it's travel lodge, back in the tent, just applied for tents, and possibly provides over the weekend for some of these young men. This can't be, acceptable long term. So what solutions do you have in place for trying to provide a longer term solution for these young people?
Firstly, I'll just say that sorry, I'm new to the commissioning too, so don't know some of that back information, although I do.
Can you speak into the microphone, because you're talking that direction, microphone's there.
Okay, sorry, just I struggle to hear if I can't see someone's face. So I'm new into the commissioning team, just on a huge restructure. So we're in the middle of transferring a lot of work over from people who've been around mental health services. But in terms of the youth service, there is an open marketplace happening next week. It's being widely advertised by the previous commissioner. So that'll be open to potential providers to talk about what they think they can bring. And the service specification for that will be co-designed. It will go through the commissioner working group where our colleagues Laura and our counterparts in Telford sit on, and then it would go to the strategic commissioning group, which the directors of public health sit on. So there's a process set in place for that. In terms of the amounts of people in the travel lodge, I really don't know. Is the honest answer to you. I would imagine, Laura, that a lot of these people present up at the homeless centre over at the council. I remember this being asked a long time ago about something else. It wasn't this subject, but it was about how many people are actually in travel lodges. And I can find that out from, I think I'll have to have a conversation with some council colleagues first. I don't want to kind of guesstimate that. And sorry, it was a third point, wasn't there?
Yes, well, how we working around.
Tracy, you need your microphone.
Sorry, when we had a private conversation. Sorry. The other question was around what are you looking towards putting in place to work with young people who have been released from prison, only to sort of have low level of mental health, but they're obviously in crisis. There seems to be little some of these people are going for a travel lodge temporarily because it's not suitable. So we're providing the sleeping rough. Do you have any plans to sort of help this particular part of group of young men predominantly? Yes.
In terms of rough sleepers, we have a commissioned rough sleepers team who have quite an assertive engagement style and will go and visit people when they're in tents and things like that and make sure that they're able to access mental health service, but also look at their access to physical health services. And they work really closely with, is it Reset, Laura, in the council, Shropshire Council as well. So they work together as a rough sleepers task force.
They are brilliant. I'm told their funding is being withdrawn next year. So that's a little bit of a concern.
I don't know about the local authority bit of it, but the NHS England funded part of it continues its recurrent funding.
Thank you. Laura, you want to come back?
Yeah, just about to add that the Reset team that sits under the Place Directorate under Laura Fisher, it's focused is very much on our MDT approach around supporting individuals into accommodation, into employment, looking at their health and well-being generally. So there's, it's a really well regarded service. I don't know if I can't mention that it was not going to be funded. I'm not aware of that, so I would have to check with colleagues across the directorate as to whether that is what's happening with it. And just I suppose to add in around it, I think the challenge always is where individuals fall between kind of needing general support and who have got social care eligible needs as well. Some of these individuals don't, and it's just ensuring that's where the Reset team really come in and support those individuals, which is really, really important. The work that we're doing around, as I said earlier on, around the units will be what we want to be able to do. And I think we've lost Leslie. I think she just told me she's lost signal completely. But what we want to be able to do is, as she said earlier, is to utilise it flexibly in terms of the needs of individuals. One size doesn't fit all. People's needs change daily, hourly, weekly, monthly, as we all will. So that's one of the things that we just need to make sure that the accommodation support is ensuring that we've got that right level of support in those new units. So, for example, if that is needed for individuals that maybe don't have social care needs, these are the conversations that we'll be having across with our housing colleagues about how best we can support individuals, and really looking at kind of where it's not like a menu, but what are the choices and what are the schemes that we've got and where are the gaps. So that is part of the work that we said earlier on that we're hoping to do, or we are doing, not hoping, we are doing.
Thank you. I gather, I know we've been proactive with farmers and rough sleepers, people like that. Are there anybody else on our radar that we think we should be focusing our attention on?
My question might answer. Sorry. I don't know who was going to speak then.
I was saying that sorry, looking at how we have farmers at risk, and you mentioned rough sleepers. Are there any other groups that we are concentrating on that we're looking at that could be at risk?
Young
What matter?
people.
Sorry?
I'd like to know if they get a reference from school, if there's a concern, how is that dealt with?
Question. Can anybody answer that? Yeah.
So schools, just like GPs, can access our access number and come through that and go through the mental health triage. So schools can refer. I don't know whether that answers the question, Peggy.
Sort of. It's just that it's usually, older teenagers, and if they can be picked up quick enough, it can save a lot of problem further down the line.
Yeah, part of the national strategy is to develop mental health support teams. We've got just over 50% coverage of the schools now. So these are small teams of mental health professionals, mostly cognitive behavioural therapists, who work in the schools. Obviously, the vision is you get 100%, but they're slowly increasing the percentage nationally across the schools. We do obviously have some schools with gaps with regard to that. And we've just commissioned a small piece of work as a pilot with Shropshire Youth Association, just to understand which schools haven't got it and what provisions they have got in place, to see whether or not we can use some grant allocation methods to get. It won't be as good as the mental health support teams. We won't have the funding for that nationally yet. Just see what we can put in to actually improve the offer within those schools. That's something that's currently happening.
Thank you.
Can I just ask a question on that? Because SYA doesn't work everywhere, and therefore will not be working with all schools. So how do you pick up the schools that SYA are not working with?
So SYA have been commissioned to do a pilot work across the whole of Shropshire, Telford and Wrekin, understanding which schools we currently haven't got mental health support teams in, and doing a gap analysis.
They're actually doing the research work around that, the whole thing. Okay.
And then feeding back to us for us to understand what we can do in terms of a grant allocation to improve the offer in those schools.
Thank you. Thank you.
Thank you.
Rachel.
Thank you. Sorry, there's a couple of points I was just going to address. The rough sleeping grant, you're right, the funding came from OHID. It was one-off funding. We've had it for a few years, and currently funding runs till 31st of March. However, we are hoping, obviously there'll be further extensions of that, but we'll have to wait until the spending review and confirmation on the public health grant. It's a great example of how we can work together in a multidisciplinary way, and absolutely a way of working that we want to embed regardless. But the actual additional funding is due to end currently at the end of March. So that's obviously an area that we're looking at and focusing on. I think there's a wider point around prevention I just wanted to raise. I think obviously there's a lot of work going on around prevention, but I think there is onus on us all, because it's the collective responsibility, what more we can do around that. Not to harp on again, but I think it's important to say that a lot of the kind of early intervention public health well-being, like, if you like, which is so fundamental, that doesn't often come with direct funding. We've just given an example of this. So it's all of our roles in terms of how we can make every contact count. I don't like that expression, but that's one of the areas. How we can, obviously the role of our community involved sector is absolutely vital in this area. So again, how do we support, look at the capacity? Some of the models that we've already got around things like hub working is really going to be important to well-being. So I think there is a really important issue that we need to grasp around what more we can do around that when funding is often short term. How do we make sure that we start to shift left towards doing embedding that much more? So I'm not going to. I just want to raise that, not from a wider system point of view. Whilst there is some good work going on, that isn't often. How do we sustain that, and how do we make that shift more visible in all of our kind of strategies and approaches? And the final bit, I think, around those groups, some of those groups that we need to work with. Actually, some of the conversations we were having, certainly, for example, around the suicide prevention strategy, starts to really focus on some of those groups that many mentioned today. So we've talked about kind of veterans in our rough sleeping community. We've talked about those at risk when they leave prison, for example. So there's our farm community, there's a number of communities, and actually that targeted approach, not just around kind of mental well-being, but also around health checks, all of those other vital offers to those communities who maybe can't get as easy access to our services as we want. So I think moving forward, our model around this needs to absolutely make sure we target some of those groups. There is some working going on, and I think maybe that's one thing that we could pick up a little bit more detail on, where we are working and where we've got perhaps gaps. And I would expect the mental health needs assessment to pick up some of that as well.
Thank you. Yeah, that's why I was pushing for our comments on groups on as to what we need to be focused on to be proactive. Prevention is obviously going to be best outcome for everybody, basically. Laura, you want to come back to us?
Thanks, Chair. Yeah, and I think in addition to your question on groups that we do need to focus and support more, I would say carers. I think we've got a huge and rely upon our carers across Shropshire as we do nationally, and we really need to look out for them and look after them. So we've obviously got our carers strategy, and we're doing more and more work. But I really feel that is another cohort or a group of individuals that we certainly need to ensure their mental health and their wider well-being is taken into account and supported as best we can.
Good. Thank you very much indeed. Ed.
Thank you, Chair. I just want to take the conversation back a bit, actually. Councillor Bentinck raised, I want to talk about the suicide issue now. You raised a lot of questions there that we would like to ask you guys today. I know you've got a future meeting with planned on suicide, so I'm aware of that, but we'd like you to ask you some questions that might feed into that meeting. Mind. So you do know, as we've just said, Bernie said, we noted that the rate of suicides per 100,000 adults for Shropshire Council area is noticeably higher than the average. You acknowledge that yourself, I think. What insights do you have in relation to this measure, as to why this is, and what's it tell you about the reasons why the rate is higher here than at the national level and for previous years? And what do you think has contributed to that? And were these people known to your services?
Yes, that's a good question. So in terms of the last bit first, probably, Rachel will correct me, I'm sure if I'm wrong, but I think the old rule of thumb used to be when you were thinking about the quantum of people that had died by suicide, it was that a third of the people probably would have been known to a mental health service, a third of the people probably would have been known to a GP, and a third of the people probably wouldn't have had any contact with anybody before. Rachel's nodding, which is a good sign, so I'm probably not far off with that. Again, that's a rough rule of thumb. I can't speak to why the rate is slightly higher here, so I'm hoping that potentially Rachel can come in on that point, or Kathy. But what I would say on the back of that, and clearly you would argue that somebody's died, it's too late, but we have an active, I think we referenced it in the slide set, an active involvement in reviewing why things have happened and looking to implement learning from those as well. So the Patient Safety Incident Response Framework, PSIRF, is the national approach that we use to reviewing all adverse events in healthcare, death by suicide being one of those. So where we spot things or trends with the people who have been in receipt of our services, we're proactively looking to make things different as well. Like I say, that's broadly speaking only a third of the quantum of people that have died by suicide would probably have touched our services anyway, so a lot will be in primary care. And then I say it's thinking about the people who, for whatever reason, don't feel they can access any sort of health support or don't want to access any health support as well. And that's a really tricky group of people to get to, I guess, because they've never even reached out in the first instance for that help from somebody. So we are an active partner, obviously, in system discussions around that. Kathy chairs a system-wide meeting as Senior Responsible Officer for Mental Health, Learning Disabilities and Autism, which focuses on the prevention agenda as well around that. And we have regular reports from Gordon Cachet from the local authority, and then Lynn Stepanian from Telford and Wrekin local authority as well. So again, it's a standard agenda item really in terms of making sure that we've got proper eyes on that as a system.
Yeah, thank you. I think it's important we hear from you today so that it can be vetted, because we haven't heard much about this information environment on this particular board. So it's bringing the information into the public domain so that we can discuss it later.
Good, thank you. How do you benchmark? Do you know you're doing a good job? I mean, how do you benchmark success in mental health? Obviously, suicides, the figures drop. But what about the everyday person, the big multitude and say, I'm struggling? How do you know that you've actually done a good job? How do you benchmark that?
Again, a very good question. Again, not a simple answer probably to it. So like I say, if you think about the individuals we work with in terms of the care plans we develop with them, in terms of the goals they set, we actively monitor those through the use of a tool, a patient rated outcome measure. We've got more than one that allows people to say and to show whether they've had the improvement that they would expect and we would expect from that. We have things like the friends and family test that people will tell us about the services they've received. We have an annual community mental health, again, this is a national thing, but we have an annual community mental health service audit as well, where nationally we're benchmarked against other people. We're part of the NHS benchmarking network as well. So all of our data is poured over alongside data from comparable trusts, and we get a rating about where we sit within that. We obviously have a range of external auditors, probably the biggest one being the Care Quality Commission, who come in and tell us how we're doing in terms of their requirements as well. We have a range of data that we produce for both internal and external reporting as well, which helps us keep track of what we're doing generally, but in terms of the key performance indicators that our contract tells us we need to deliver on. Those are discussed at our contract review meeting monthly with Jackie and colleagues. What else have I missed, Kathy? There's probably a whole load of things. I say there's not one simple thing, but there's a range of metrics, and again, learning from adverse events as well, learning from serious untoward incidents using the BSERV process. We will do that within teams and across our care group, but we also learn across the organisation as well. So if something's happened and there's some useful learning in one team or service, we'll make sure that we've shared that across the organisation so that we don't see the same bad thing, whatever that bad thing was, we don't see the same thing happen again somewhere else as well. So a whole spectrum of things, but
so some of the tools that we use are the REQUAL tool, which is a patient rated outcome measure that looks at the quality of life for people with different mental health conditions. There's another tool called GBO, which is looking at the goals that people want to achieve within their care plan, and it looks how far that person has progressed towards achieving those goals. There's also a number, as Paul touched on, national audits. So for particular services, for instance, the early intervention and psychosis service, there's a national clinical audit of psychosis that happens annually, where you're expected to achieve different levels. We achieved level 4 in that. Only 60% of trusts have a target of meeting that. So some of the benchmarking shows that we're doing well. More recently, and it touches on your earlier question, Chair, around what groups we should be focusing on, we also look at learning from other areas. And obviously there was a lot of learning in terms of mental health, in terms of Nottinghamshire, with the homicides that tragically happened around Balder Colcane. And we've just had to develop a maturity index and complete that to see how well we are doing in terms of service development for that particular cohort of patients who are more difficult to engage with, need much more assertive engagement techniques around them. And although we are probably compliant against the CQC report that was developed, there is some development action plans that are needed for that cohort of patients, with probably further investment needed in services, because the national guidance says we need dedicated nurses, dedicated psychiatrist time for that cohort of patients, and we currently haven't got that. So that again is another area of focus for us going forward. So the benchmarking is useful. These sort of dashboards that come up from NHS England are really useful to compare us with others and look at what our development path needs to be.
Thank you for explaining that, because the way I read it is that we've got a lack of beds, we've got a lack of finance, we've got long waiting times. Do we really have a sustainable, rosy future? You know, and is there what's the barriers to you progressing and actually overcoming these problems? Are you actually challenging budgets and funding and staff training and those sorts of issues?
So about 6 years ago, when we benchmarked funding in mental health per head of population in Shropshire, Telford and Wrekin, we were the second lowest in the UK. I'm really pleased to say that we've received the mental health investment standard targets funding. We've received a lot of service development funding over the last 5 years, and we benchmark sort of fairly average now in the West Midlands in terms of funding per head of population. It would be true to say that the funding that we've received has been targeted nationally against the National Strategy for Mental Health, but our waiting times have come down, even though we've been doing that within the context of increasing demands after the pandemic, and also with some of the cost of living crisis that some people have suffered since the pandemic.
So it's not true. I understood that we were the lowest funded.
We were the second lowest about 5 or 6 years ago, but that has changed significantly. We're around about average now in the West Midlands.
Oh, in the middle. We're in the middle now.
In the middle.
That's good. Any other progress? Any other barriers we need to demolish?
I probably had my finger up slightly before that question, sorry. So I don't know about that, but just going back to the slide set that we've provided as well, slides 7, 8 and 9 show some of the improvements that we've already made. The first one talks about the number of people waiting for community mental health intervention has come down, and the length of time that they're waiting has already come down. Slightly lower rates of improvement in our NHS talking therapy service, but you'll see those accelerate from now. We've been in with the major sort of reorganisation of the internal work into those services, I suppose. But again, the waits for the 18-week waits are virtually eliminated now. We're down to sort of double figures from over 4 figures 2 years ago, really. And then if you look at the, I can't remember what line was, the number of people who are re-referred back into our services as well. So although, particularly with severe mental illness, cure is not a word we would necessarily use. It's a lifelong experience for people sometimes that gets better or worse over time. But again, if you look at slide 9, it will show you that the number of people who are coming back into services, while still a concern, has reduced by a couple of percentage points from where it was. And you know, in a very simple answer to your first question as well, really about how do we know we're getting it right or not? People tell us. Our partners tell us, the people who use our services tell us, our GPs tell us, etc. So we get a lot of feedback as well that comes from people about how they see the things we've done or not done potentially for them.
What can we as an authority do to help you achieve more? Is there anything that we're sadly lacking?
I was going to come at it in a different way and say where we've worked really, really well together has been particularly around patients who need mental health rehabilitation. We had an awful lot of patients out of area with regard to that. We've done some excellent work with both Shropshire and Telford local authorities in terms of bringing people back, look at the housing. That links to some of the housing projects that Laura touched on before. It's been a real credit in terms of the joint working that's been going on there. And then obviously the prevention work. Obviously the local authority are responsible for more of the universal type prevention, but by working more closely together, we can actually make the most of some of the NHS money, the grant allocation that we've got. We have lots of rules around that. So Rachel and I have been having some recent meetings talking about how I can still comply with the rules, but we can work together. And the next thing we're going to work together on is suicide prevention and how we can use some of the grant allocations around that. So it's just a case of there's lots of rules in the NHS and how we can spend the money. I'm sure there also is in the local authority, and we just need to make sure that we can do it by complying with the rules, still making a difference to people.
Thank you. It's nice to hear that everyone appreciates what Rachel and Laura do. We all do, but I just wonder if there was anything in particular. And it sounds as though you're very happy with the service that we provide you.
The only thing that has been tricky of late, and Paul touched on it earlier, is that we have had people with clinically ready for discharge, particularly some of the older people, where there have been some delays around the discharges, but actually recently we've done some great work together on that, and we just need to keep that up really, and use some of the new ways of working that we've got around the MAID events. And I'm sure it's both sides of it. One of the things that we want to do is invest in a clinical flow manager will help us with regard to that. There's work for us to do internally at Redwoods as well with regard to that. And we're just going out to recruit to that post.
What's a clinical flow manager do?
So they make sure that people are you're considering discharge from the point of admission, and that would include some of the housing issues, the one that you touched on earlier, to make sure that we are considering the housing that somebody needs at the moment they get admitted. It also makes sure that they're having the timely therapy that they need on the wards. So we're minimising the amount of time that they need to stay in hospital. So everything is make sure it's productive in terms of the admission.
Thank you. Sounds interesting. Good. Heather.
KPIs are only as good as the KPI. They don't necessarily measure what we need to know. And if they're set centrally, which they are, they're not always as informative or as useful to us as they might be to NHS England. So, do you have any local KPIs that you use around rural Shropshire, which would be very interesting? I'm also interested in looking at, I'm pleased to hear that the funding was increased, but if we're now average, how does that sit alongside the other rural counties rather than the West Midlands, which is very urban centric? And yes, I think that's basically what I wanted to ask. You talk in the slides about some of the feedback from residents and so on, but actually some of those case studies will be quite useful to us, but on both sides, the complaints, the learning that you've done, but actually on the other side too.
Chair, I'm happy to take outside of this meeting and see what more we can do if you'd like around the rural work.
The answer is going to be yes, please. Thank you.
So you haven't got the figures in comparison with Herefordshire or wherever? Okay, thank you.
Good, thank you. Well, you'll be sorry to hear we're running out of time, so we do plan on having further meetings.
Did we have local KPIs?
Yes, they've just offered to do that.
You've got some? No, I thought they were talking about the funding issues across rural counties.
Sorry, yes, we do have some local KPIs that are agreed with commissioners as well, but they're always under review every year, really. In fact, I would hazard a guess off the top of my head without looking at the spreadsheet that the majority of the KPIs we've got are locally defined ones rather than national targets. I think most of them. Yeah.
Name them straight away, but most of them are about what's the need for that community. How's it going to hit that community?
And for Shropshire, rather than the West Midlands or wherever?
No, it would be.
It would be useful to know exactly which ones are local and which ones.
I can find out. It will stay within a contract, so I'll need to check first.
Good. Thank you very much indeed. Jackie, can I turn your mic on, please? Thank you. I think we need to draw a line under for today. There are all sorts of things that have arisen from today's conversation. You know, the comments that Bernie made about commissioning and so on. Something we do need to look at. Suicide, we definitely need to look at. Excess deaths in the communities. All sorts of issues that we need to spend more time on. So, but I would like to say thank you for coming today and thank you for answering my questions. It can't have been easy because they were all random and they were not in a particular order. They didn't flow very well, I thought. So that's probably down to me. I apologise, but thank you for what you've done. It has been informative. Before we move on, because we need to move on, is there anything you want to ask us? Or are you happy with the way things have gone today?
Yes, very happy with the way things have gone today, and just I guess thanks personally for the focus you're putting on mental health in the local authority. I think it's really welcome. And I think if that means that we are under scrutiny as a result of that, that's so much the better, to be honest with you. We've seen a real shift, I think, over the last, I don't know, couple of 3 years, maybe, I think, into terms of mental health being much more mainstream in discussions in major institutions. So the fact that it's on the table for discussion here is a really welcome thing from our point of view.
Good, thank you for saying that. That's appreciated. Thank you very much. You can go if you wish to go, if you've got lots to do. We're going to move on now to item 7, update from the Health and Wellbeing Board.
Thank you, Chair. So we've circulated to everybody the agenda and the annotated agenda from the Health and Wellbeing Board, which took place on Thursday. A couple of the items on that agenda we've already brought today, so I won't go through in huge detail. But as you know, the agenda is split into 2 parts. The first part, we have discussions, so we have papers presented as a brief presentation and then an opportunity for more detailed discussion. The 2 items for more detailed discussion, the first is the suicide prevention. So and I've asked Sophie to make sure that we share those papers with yourself. There was what actually we probably haven't shared is the presentation, but I will share that as well with yourselves because that was circulated after the meeting, which I think will answer some of the questions that have been raised, and I expect that will be presented ahead of the conversations that you want to have in more detail in November. Just a couple of key points from there, I think, just in answer to the questions that were raised previously. So the initial audit that's been undertaken of 140 inquests with a verdict of suicide between 2020 and 2023. Just some more information for yourselves. The majority were male, majority were aged 35 to 54. There wasn't any significant difference by deprivation. 50% were in employment, agriculture being one of the main employments, manufacturing, building, construction, professional, technical and health, which again mirrors some of what we'd expect to see in the county, but certainly the conversations that we have been having in terms of patterns, and 25% were retired. I think you asked a question around risks, and again, that was the risks in life events prior to death included previous suicide attempt, relationship breakdown, bereavement, financial concern, which again goes back to some of the concerns we've been having, physical decline in health, and common illness has been reported, and adverse childhood experiences. And the last contact with services, in the majority of cases, that was the GP. And then just under a third of those were non-mental health services, which confirms the what was raised just previously. So within that, there was a summary of progress in terms of the 4 pillars of the suicide prevention strategy, and making sure that we obviously address all of these points in the most recent cases. That presentation, there's a considerable amount of work going on, but I just actually wanted to draw your attention to the fact that there is some training that's been put on for members, and beyond that, and you'd be all very welcome and invited to that. There's a number of training sessions, but there is one this week. So I've just again asked I did ask that was circulated, but if you haven't had it, to make sure that you've all had the opportunity to be invited. There will be other training. There is some free training that's offered around from the Zero Suicide Alliance. But I guess I won't talk about that anymore because we'll have an opportunity to get into much more detail into that. But within that pack and within the information I've shared, there's lots of information about where to sign up those people too. The other items that were picked up on the agenda, we had a good discussion around the inequalities plan, which you'll remember went to, it was endorsed by the Health and Wellbeing Board in November 2022. I've lost track of the years. And went to Cabinet and Shropshire Council and was further endorsed. That was our first inequalities plan for Shropshire. There was a very comprehensive plan and actions within that, and this was the first attempt to report on progress around those actions. And actually, all the more important on the back of the DARS report that's just come out, that obviously people will be cited on, that continues to talk about inequalities, although not specifically rural inequalities, which again I think is something that the Health and Wellbeing Board felt strongly about. We need to make sure that is recognised in national policy, as well as obviously continuing to push on that. There was a theme that came out of the board that I'll come back to in terms of outcomes from a couple of the papers. So they were the 2 key discussion points that demonstrated that the movement that's being made both around the suicide prevention agenda and the inequalities, notwithstanding there's a lot more to do still. And so Scrutiny might be interested in looking at those, obviously in terms of suicide, but also I would suggest in terms of the inequalities plan and the progress being made across all partners around inequalities in Shropshire. There was a number of other areas we did discuss the rural proofing report that was well received and actually tied very well into the inequalities conversations that were being had at the board prior to that. And then with some discussion around the Children and Young People's GSNA was brought to the board and signed off. There's some really important outcomes and recommendations within that report that we now need to make sure are being taken forward into the commissioning plans. And again, that in a future work programme, that may be something this committee particularly interested in. Some of the outcomes you would be very familiar with in terms of where we would expect to have, we need to have much more focus on improving outcomes around health care as well. And some of the actions that have been taken. We also had the cost of living dashboard and the first version of the integrated care partnership outcomes dashboard, just some very high level outcomes just to try and monitor what difference this work is making. But I think one of the themes that came out of the whole of the board was really absolutely the need to monitor outcomes in a way that's meaningful, but how do we also make sure we get people's voices within that as well? And that was something we've taken away as a board and support some of the public health work we do in the population health management with NHS colleagues to make sure we really embed that in so we can say it's making a difference. There was also a brief update on the women's health hubs as well on the agenda and how that's linking to our own hub programme. So again, not trying to do things differently, but actually starting to build some of these programmes together. And so that was the overall conversations at the board. I think, as you said, particularly relevant would be the suicide and the inequalities papers and the need to make sure we are delivering those outcomes. And the need to also make sure the outcomes reflect what people are actually feeling on the ground.
Thank you. Heather and I, as you say, you came to the change your meeting, listened to part of it, and it was interesting, as you said, that things sort of joined together, the discussions on rurality and so on were being approached by all sorts of different groups. So it's I think we're all going in the right direction. So thank you for that.
Thank you, Chair. I have three brief questions. The first is around the report from the Health and Wellbeing Board. The meeting was actually 2 months ago, but we're having a verbal update. Is there, as this is a scrutiny committee, is there no way of having a written report for this committee to look at? So that's the first one. The second is about suicide prevention, and it's been previously well recognised that former attempts at suicide are a marker. And is this a statistic that's being kept? And what are the interventions or strategies used to help people to not commit suicide or not attempt suicide again? And the third question is about the GSNA for young people, and particularly in Shrewsbury. The report I see from the papers has been completed, but I don't believe that it's available, or at least I haven't seen it. And there are some particular areas that I would be interested in, as well as the general report. I've, as you know, previously stressed the situation in my own ward, where a small area of that has got very high levels of multiple areas of multiple indices of deprivation, and it hasn't really figured very much in the correspondence to date.
Thank you. So if I just so the meeting that I'm referring to happened on Thursday, last Thursday. The board does meet roughly every 2 months. So I think the papers that I'm referring to in the agenda, I'm not sure if I'll double check which one's been circulated, but it was just Thursday just gone in terms of the meeting.
Right. It says here 16th of July. It says here 16th of July on the agenda.
Oh. Does it say is the first item suicide?
Update from the Health and Wellbeing Board. The agenda from the meeting can be found on Tuesday, the 6th of July, 2024.
Apologies, I'll make sure the right one's circulated.
We can check on that, but Rachel says the meeting she's just reported on was last Thursday.
Has the July one been circulated?
But because there's been more, because there's been more than one meeting in between, the July one has come forward to this session, so it looks like there's one that's been not picked up, so we can make sure that that doesn't happen again, and it will be rectified.
Yeah. Sorry, I've just completely confused everyone. So I was referring to the meeting that was held on Thursday last week, which went through those items that I've just gone through. Apologies. In addition to what you will have seen, I can't remember what happened in July. I'll need to go back and double check what we reported in July. But I've just reported to you the meetings from last week, which I think are the first two are particularly pertinent and relevant to this board, and you may want to do some further scrutiny. And I think the issue around outcomes was the GSNA is the Children and Young People's GSNA. It's not specifically the place-based GSNAs that I was referring to again, so apologies around that. We do thematic GSNAs alongside doing the place-based GSNAs. I will endeavour to find out where the place-based GSNA is for Shrewsbury. In terms of the one that was published at the Health and Wellbeing Board last week, it was 2 chapters of the Children and Young People's thematic GSNA, focusing on children and people. It was the 0 to 5s and the next age group as well. So they were the 2 chapters that were published particularly. They take more of a county-wide, but they do get into some of the detail. The place-based GSNAs will go into much more of the detail of your locality. And apologies, I've forgotten the last question.
I'll be interested in both. Both the children and young people and the place-based one. Is the children and young people's report available to members?
Yes, it's on the website. So the two documents, I think it's about 200 pages, one of them. So it's quite a detailed report in terms of children's mental health.
And when do you anticipate the place-based one?
I will find out where we are with your particular area. They're all staggered at different times, and obviously the team are out there trying to complete the rest of them by the end of this year, but there'll be a time then for publication and to come back on that.
Thank you. And the other question was about previous suicide attempts.
So there is, as part of the work programme, there is detail, because you're right, that's one of the known risk factors. That's one of the reasons that we put, we've actually tried to get we've got additional funding to support people who have either had a previous event experience. So that is some of the work that's been undertaken. I haven't got all of the detail. I think probably in terms of time I need to go and I'll invite Gordon to the next meeting. I'll be able to give some of that level, but that is one of the areas that has been focused on. Also in terms of bereavement support for those who are bereaved by somebody. We've got a particular investment for children and for adults around that. Again, we put in through some of the monies that we were able to use through COVID. Notwithstanding some of this doesn't come back to my earlier point around long-term funding for this, but there is recognising particularly that point of how we monitor people, how we put additional support in for those who may have attempted suicide previously or are bereaved by somebody. We put additional support around those because they are risk factors, as you already said.
Part of my question was about the register of previous suicide attempts and how many people. So what kind of effect the interventions are having on reducing the risk of further suicide events or actual suicides.
So if we can take that as one of the key lines, we can make sure that we bring that into the next meeting and we can get some information.
Thank you, Richard.
Good, thank you, Tom.
Yeah, it's just quickly, because I don't want to sort of stifle this too much. When we get to the work programme, I've made a note of quite a few potential areas for briefing or further briefings, which will come out of today's conversation. And I think that bit on the suicides and some of that focus is something we've talked about previously in terms of the run into the next meeting of the committee. There's a lot to get into. Bernie, your questions just demonstrated some of that complexity. And I do think it's one of those areas where it's worth that. It's proven by this committee and others to use the briefings to dig into some of that information beforehand to get the understanding, to bring the focus in. So when we come to the work programming, we'll be able to share back some of the points which are potentially pertinent for briefings for you to decide whether or not that's a reason to take.
Thank you. And I think the things are going to emerge from today's meeting. I don't think Peggy got a proper answer to a question about young people and how they're picked up in school and how that moves on. So I know the People Committee are going to be looking more into this topic, and I'm sure that our committee will as well. So that there is a lot more informal meetings or discussion to be had on these subjects. Right, okay. Item 8, update from the Joint Health Overview and Scrutiny Committee.
Thank you. So I'll just give a brief overview and then I'll hand over to the Shropshire Council Joint Host members to add any further detail. So the last meeting of the Joint Host took place in August even, and that reviewed the May Shrewsbury and Telford Hospital Care Quality Commission, so the CQC report, but also looked at it alongside the aired Channel 4 dispatches programme, which was focused on the Royal Shrewsbury Hospital, the Accident and Emergency Department, and triangulated their previous work along with the report and the documentary. The key discussion and outcomes of the meeting was that it was very much focused on the CQC report's findings, particularly around urgent emergency care, which has already formed a key focus for the committee. And the members were really seeking assurance that actions were being taken to alleviate overcrowding and address safety and safeguarding concerns, which they highlighted in both the report and the dispatches programme. It really stressed the importance of transparent communication and the wish to see the implementation of robust action plans with clear timelines. The main outcome from the meeting was that it was agreed that the committee would work alongside the Integrated Care Board and staff officers in an informal working group to focus on the Trust progress and the sustainable delivery of the must-dos and should-dos from the report, which was stipulated. From this work, the committee have agreed that going forward, their next focus will continue to be urgent and emergency care, to build on the work they've already undertaken and the new learning through the August meeting, and they've therefore arranged meetings with West Midlands Ambulance Service to support this work, as well as working with the Director of Public Health, Integrated Care Board and staff officers to understand work being done within the system on excess mortality. So there was a lot covered in that meeting, a lot of evidence to be able to be heard, and that's taken the committee through to there.
Yeah, that's broadly the focus that we said we'd follow. Councillor Bentinck.
Thank you, Chair. I wrote to you and the officers and several others on the 18th of September regarding the guidance published by NHS England onto what they call transitional emergency spaces, which is a term that encompasses corridor care, but also other areas where people are housed temporarily, but inappropriately, while waiting for the correct area to provide care. There were a number of areas that each trust was instructed to follow, and so can this be encompassed in the working group's request to Shrewsbury and Telford, and particular attention was drawn in that document to the ability of the freedom to speak up guardians who many of whom have felt reluctant to speak up because of the fact that they're not only employed by but also answer to Shrewsbury and Telford management. And some aspect of this, in my view and others, really should be independent.
Yeah, I agree, and I'm sure that we will be able to avoid those with the working group. Because one of the topics that I get mentioned was staff retention, how staff were treated, and so on. So that really does come under that, because that Channel 4 report did actually show staff feeling undervalued. I think they had an ability to tell people exactly what they wanted to do and perform their jobs. They accepted failure. So that's something that we did actually mention at our meeting, and I'm sure it's something that we need to follow up on.
Thank you, Chair. If I could just say one or two more things. The NHS staff survey for Shrewsbury and Telford Hospital precisely documents this problem. And year on year, staff are reporting that they feel frightened to speak up. And while words are said that would supposedly produce improvement, it doesn't happen. I myself experienced some of the adverse culture while working in the hospital. Since leaving SATH, there are those employed by the trust and volunteers who've reported issues to me personally because they felt scared to speak up, and also scared that I intervene on their behalf because of worries about victimization. So this is a real problem. The culture in trusts across the UK, as well as in South, is something that needs urgent attention.
Thank you. Couldn't agree more. Sorry, we need to move on because we're out of time. Item 9, work programme.
We are short of time. I can hand over directly to Tom. So,
Yeah. Hopefully. So, in terms of your work programme currently, I think the next meeting work programme topic is on the care transformation programme. In the build up to this meeting, and I think has been evident in the conversation in this meeting, mental health as a topic feels like it's the topic for the year, pretty much, for the committee. And based on, and with the committee's agreement, if that's the case, I would suggest that your next meeting, the focus on that really does move towards continuing this conversation, but being more focused, as Rachel said and you said, onto suicides and onto that sort of. There's a metric which is in our, or a measure that's in our corporate reporting for the Shropshire Plan, which picks up on, I think it's death related to serious mental illness as well. So there's an opportunity to bring that together. It picks up on the issues you've got here. It might pick up in other areas, and wrapped around them, I think that is scope to put some briefings in as well. So I would suggest that building on from today, again, if it's agreement, and Rachel, please check if I think there's anything that we shape some of this as well. Possibly something further on the commissioning and investment in mental health services. I know what Bernie was saying, Councillor Benton was saying earlier around the case which he brought to the attention of the committee. I suppose from my statutory scrutiny officer perspective, I want to draw back to best practice and say if it was a complaint, a person raised, we wouldn't take a single complaint. But as a committee, you might want to understand more about the context and more about the situation that's within. So I would suggest, what's the context for all of the commissioning? How all those needs, which we've sort of touched on today, being met, build all that through and use one of those briefing sessions to understand all of that. If there is something to follow up on, absolutely, it would make good use of committee time to, if there's an agreement to do that. So that might be something there. I was particularly interested, and I thought some of the members were around the table as well, the conversation that was picking up on the issues around housing providers, and where housing fits within mental health prevention, and those other matters. So that might be something, I mean, I haven't got a scope for that particularly, but I think that could be something that's useful, and maybe pick up on the wider determinants of health within that piece. Which will play out against what public health focus will be on this. You might want to suggest a briefing around the children's JSNA and what's coming out of that more widely. So it might not be just this now, although Rachel's sort of the first report she published, but that wider piece going forward, because if that's fresh thematic needs assessments, it could be some very pertinent information coming through from there. There's a couple of bits a bit for me in relation to this was listening to that, and it might be a piece of work that needs to be commissioned, but it's around, are there those common themes like housing, matters which affect more than one of those client groups, which could be joined up, and are those solutions in place across the piece? There were two pieces of work that came out of the conversation with colleagues at the Foundation Trust in terms of that follow-up and comparison with other areas. And it might be that, you know, through Rachel, it's about saying which areas we think are the best comparators in terms of rural areas, because we will talk about local authority rural areas, but to the NHS, if you're talking to the ICB, they will talk about DP practice geographies or primary care networks. If it's something on the scale of MPFT, we need to maybe define what we mean by similar areas, because we'll automatically jump to Cornwall, Devon, Dorset, Herefordshire, Wiltshire, Sunderland. Those are the ones we automatically recognise because of their rural sparsity and similarity to us. So it's just being clear to them where we are. And the other one is that piece of local in the Mental Health Commission contracts, just so, again, I suppose from our office perspective, just making sure that those are followed up on, put in place. So I think a few briefings, suggesting that you might want to continue your focus on mental health for the remainder of the year. And definitely, I think from the sounds of suicide, and the other point that's been flagged around suicide is your next meeting's late November. That's the run up to the festive period. Again, back to the references you made to things that should be sort of well understood. That's the period of time which can be very hard for people. They're festive period, which don't think by themselves alone or struggling, or there are things which are true and we can have for it. Yeah, good to see you.
Good, thank you. I don't know how we felt about today. I wasn't too happy with some of the questions, some of the answers we got and stuff. But there's room to expand on that. Thank you for that. Thank you for coming. The date of the next meeting is, when's the date of the next meeting going to be? 25th of November, I'm told. On that, it is. Thank you very much indeed. On that, can I say thank you very much indeed? And can we call the meeting to an end? Can we stop?